Good morning, everyone. Today we are going to talk about heart failure and the different compensatory mechanisms that are employed by the body to restore the cardiac hemodynamics back to normal. First, let's go to the objectives. The first objective is to recognize the factors that predispose to heart failure, such as hypertension, coronary artery diseases, vascular heart diseases, and cardiomyopathies. The second objective is to explain the causes of dyspnea, nocturnal dyspnea, and fatigue, as well as cyanosis in heart failure. Then we'll describe the sympathetic and renal compensatory mechanisms in heart failure, including the endocrine component of the renal compensatory mechanism. Then we'll try to understand why increased sympathetic drive can improve and worsen heart failure. Then we'll illustrate the Starling forces that produce pulmonary and lower lymphedema in heart failure patients. Objective number 6 is to understand the role of low pressure receptors in large veins, atria, lungs in controlling blood pressure and blood volume in heart failure. And then we'll describe the conditions that can worsen heart failure, including anemia, pregnancy, obesity, diabetes, infections, arrhythmias, and endocrine disorders. And finally, describe the principal investigations which aid in the diagnosis of heart failure. What is the essential function, or what are the essential functions of the heart? The essential functions of the heart are to cover the metabolic needs of the body tissues, and these are in forms of oxygen and substrates or nutrients by providing an adequate blood supply. The other function is to receive all blood coming back from the tissues to the heart. And if we have a normally functioning heart at rest, the venous return that is received by each ventricle, we are talking about the right and left ventricle, is exactly equal to the cardiac output from the respective ventricle. So the heart will pump exactly the same amount of whatever it receives in the forms of venous return. And if we have a cardiac output that is equal to the venous return, in such condition the right atrial pressure will be 0 millimeter mercury. So the essential conditions for fulfilling these functions, or to have such a state of equilibrium with the right atrial pressure of 0 millimeter mercury, are to have a normal structure and functions of the heart, especially the contractility of the ventricles, and to have also adequate filling of the hearts by blood in forms of, or in the form of venous return. And this will determine the preload that is affecting the force of contractility according to the Frank-Starling law of the heart. What is heart failure? The definition of heart failure is it is a pathophysiological condition in which the heart as a pump is unable to meet the metabolic requirements of the tissues for oxygen and substrates, despite the venous return to the heart is either normal or increased. Some students believe that heart failure is always associated or always caused by low cardiac output, and this is a wrong concept. So in heart failure, cardiac output could be low, could be normal, or could be high. But what is the main issue in heart failure is the inability of the heart to meet the metabolic requirements of the different peripheral tissues. It is a complex syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the heart to function as a pump to support a physiological circulation or a normal physiological circulation. In heart failure, we have either one or both ventricles might progressively weaken and fail. So we can have right heart failure, left heart failure, or both ventricles or biventricular heart failure. When a failing ventricle is unable to pump out all the blood returned to it, the veins behind or proximal to the failing ventricle will become congested with blood, and this will lead to the appearance of different symptoms and signs in a heart failure patient. In heart failure, what will happen? We will lose the balance that we previously saw in the previous slide, where we have a high venous return and low cardiac output compared to the venous return, and in such condition the right atrial pressure will no longer be zero, it will be above zero. It will be several millimeters mercury above zero, and this is the condition of a failing heart. What are the different causes of heart failure? We have different causes of heart failure. Some causes are very common, other causes are least common. Heart failure may occur for a variety of reasons, but the most common are damage to the heart muscle as a result of impaired circulation to the cardiac muscle, and this is in the form of coronary artery disease, coronary ischemia, and and myocardial infarction. The second cause is prolonged pumping against chronically increased afterload. So the heart is trying to eject blood against high resistance, and common examples are stenotic semilunar valve conditions like aortic stenosis, pulmonary stenosis, or sustained systemic or pulmonary hypertension. So here we can see the main causes in terms of percentage. Ischemic heart diseases, where we have low blood supply or no blood supply to the ventricular wall through the coronaries, and this accounts for 35 to 40% of the heart failure conditions or cases. Then we have cardiomyopathy and the dilated type or form of cardiomyopathy, and this accounts for 30 to 34% of all heart failure patients. And then we have the common condition hypertension, which accounts for 15 to 20% of heart failure cases. Other less common causes are cardiomyopathies, the undilated forms like hypertrophic cardiomyopathy, restrictive cardiomyopathy, valvular heart diseases. We have congenital heart diseases like atrial septal defects, ventricular septal defects, alcohol and drugs, hyperdynamic circulations, especially in anemia and thyrotoxicosis, right heart failure such as right ventricular infarct, pulmonary hypertension, and pulmonary embolism. Other causes like tricuspid incompetence, arrhythmias, pericardial diseases, and infections like Chagas disease. As I said, the most common three causes of heart failure are ischemic heart diseases, cardiomyopathy or the dilated cardiomyopathy, and hypertension. How to classify heart failure, or what are the different types of heart failure? We have four main ways of classifying heart failure based on which ventricle, anatomical classification, functional or hemodynamic classification, and other two classifications. So let's start with the anatomical. We have either left heart failure or right heart failure, or biventricular heart failure, where both ventricles are failing, the left and right ventricles. Left heart failure results in a congestion in the veins proximal to the left ventricle, and this is the pulmonary circulation, so we'll have pulmonary congestion. In right heart failure, the congestion proximal to the right ventricle is in the systemic circulation, so we have systemic congestion. The second way of classifying heart failure is systolic and diastolic, or we call it forward heart failure and backward heart failure. Forward for the systolic, backward for the diastolic. So systolic heart failure results in low cardiac output and low arterial pressure. Diastolic heart failure, here the ventricles fail to fill with the adequate amount of blood during the diastole. So there is less or low venous return, results in congestion proximal to the failed heart or to the failing heart. So the failing heart is unable to fill properly during diastole. And if we have less filling during the diastole, then we have less or low stroke volume. Then we have the third way of classifying heart failure is acute and chronic heart failure. You will see in the clinical life that acute, sometimes they say less than 6 weeks, and chronic more than 6 weeks, or symptoms and signs less than 6 weeks, and chronic more than 6 weeks. But to make things simple or simplified in heart failure, acute heart failure, the hemodynamic derangement is severe enough to result in obvious symptoms at rest. So the heart failure patient will have symptoms at rest, and then we say this patient has an acute heart failure. Chronic heart failure, the circulation at rest or the cardiac output at rest is adequate for supplying oxygen and substrate to the tissues, but the circulation or the cardiac output is inadequate during daily activity, walking, climbing stairs, doing some mild exercise. So the patient has poor cardiac reserve. Then we have another, or the fourth classification of heart failure is the low and high cardiac output heart failure. So some kinds or types of heart failure, the cardiac output is low. In other types of heart failure, the cardiac output is high, such as in thyrotoxicosis. So which way of or which type do we use for the classification of heart failure in different patients? We can use the combination of four. So we can say left or acute left systolic heart failure, or for example biventricular systolic or chronic biventricular systolic heart failure, and so on. So we can use a word from each of these four ways of classification. Okay, just to add here before we finish this slide, low output failure like in cardiogenic shock, high output failure, example severe anemia, and hyperthyroidism or thyrotoxicosis, as I previously mentioned. So we have different, as I said, we have congestion proximal to the failing heart. So these symptoms and signs will depend on which ventricle or which side of the heart is failing. So if we have, as we see here, right heart failure, there will be congestion of the peripheral circulation, especially the venous side of the systemic circulation. So we'll have dependent edema or lower limb edema and ascites where fluid accumulates in the peritoneal cavity. Back pressure on the venous or the veins draining the GIT will lead to GI tract congestion. So especially the mucosa becomes congestion. This will lead to anorexia or less appetite or low appetite, GI distress, and loss of weight. Congestion of the liver will lead to hepatomegaly as a sign, and also impaired liver function tests, as if blood test is done. On the other side, if we have left heart failure, there will be a decrease in the cardiac output. So less blood is ejected into the systemic circulation or into the aorta, and this will lead to low oxygen and substrate delivery to the tissue, and this will lead to activity intolerance and signs of decreased tissue perfusion, peripheral tissue perfusion. Congestion proximal to the failing left heart will lead to pulmonary congestion, and this will lead to impaired gas exchange and will be seen as cyanosis as well as signs of hypoxia. Also, pulmonary edema can lead to cough with frothy sputum, orthopnea, and paroxysmal nocturnal dyspnea. I will explain more the orthopnea and the paroxysmal nocturnal dyspnea in one of the coming slides. Okay, so here we can see the possible signs in a patient with the right heart failure: raised jugular venous pressure, hepatomegaly or enlarged liver that is palpable on abdominal examination, ascites, accumulation of fluid or transudate in the peritoneal cavity, plus pitting, lower lymphedema or peripheral edema, especially in the lower limb. In left heart failure, the jugular venous pressure could be slightly or moderately increased, but the marked signs are pulmonary edema, cardiomegaly, and pleural effusion. Pulmonary edema can be discovered upon auscultation of the lungs, while cardiomegaly and pleural effusion can be detected by the chest X-ray. Again, here there can be some pitting edema, but this could be mild to moderate and less than right heart failure. So the symptoms and signs of heart failure: in acute left heart failure, pulmonary edema, and the pulmonary edema in acute left heart failure can be lethal or can lead to death in 20 to 30 minutes if it is not taken seriously and treated immediately. So the pulmonary edema can lead to cyanosis due to the derangement of gas exchange across the respiratory membrane, dyspnea, which refers to the sensation of difficult or uncomfortable breathing. It is a sensation of air hunger resulting from failure of the heart to pump sufficient blood to the tissues, thereby causing tissue ischemia. Also, the pulmonary edema can lead to stimulation of the J receptors, and this will add to the uncomfortable breathing sensation. Orthopnea is the sensation of breathlessness in the recumbent or supine position, relieved by sitting or standing. Why the patient will have breathlessness while supine? Because being supine will relieve the effect of gravity on the venous return. So this will increase the venous return. The failing heart cannot cope with the increased venous return, and this will lead to more pulmonary edema and orthopnea. The other symptom is paroxysmal nocturnal dyspnea, or PND, is a sensation of breathlessness or shortness of breath that awakens the patient from sleep, often after 1 or 2 hours of sleep, and is usually relieved in the upright position. So usually the patient will add 2 pillows or will sleep at 45 degrees. So this will relieve the dyspnea because this will bring the effect of gravity on the venous return. Left heart failure, where there is low cardiac output, will decrease oxygen and nutrient supply to the peripheral tissues, including the skeletal muscles, and this will lead to another symptom, which is fatigue. So the patient will be tired and cannot perform activities easily. And in chronic right heart failure, not the acute form, the chronic form of right heart failure, the peripheral edema due to the fluid retention by the kidney as a compensatory mechanism will lead to lower lymphedema, ascites, and hepatomegaly, as we saw in the previous slides. Now in the second part of the lecture, let's talk about the compensatory mechanisms that are employed by the body to recover the cardiac hemodynamic back to normal or near normal. So what are the different compensatory mechanisms that are employed in heart failure? First of all, we have the sympathetic stimulation. It is employed in the acute stage of heart failure. It starts within few seconds and becomes maximal within 30 seconds after the onset of the heart failure. So it is an immediate compensatory mechanism that is employed in the acute stage of heart failure. The second compensatory mechanism is the renal compensation. It is employed mainly in the chronic stage of heart failure. It starts after the first few minutes of the heart attack and lasts for hours to days. Compensation for acute heart failure by sympathetic nervous system reflexes occurs as follows. In heart failure, there is a decrease in the cardiac output below the metabolic requirements of the body, and this will lead to the activation of baroreceptor reflex, chemoreceptor reflex, and the CNS ischemic response. Activation of all these reflexes and the CNS ischemic response will increase the sympathetic activity with reciprocal inhibition of the parasympathetic division of the autonomic nervous system. This will lead to increased contractility, and this will increase the stroke volume. Also, sympathetic stimulation will increase the heart rate. Increasing the heart rate and the stroke volume will lead to an increase in the cardiac output. Then, sympathetic stimulation will also cause vasoconstriction, especially venoconstriction, the constriction of the veins, and this will increase the mean systemic filling pressure and the systemic circulation. An increase in the mean systemic filling pressure will increase venous return. An increase in venous return, according to the Frank-Starling law, will increase the cardiac output. Additional sympathetic stimulation or additional effects of sympathetic stimulation include cutaneous vasoconstriction, and this will lead to pallor or pale skin in heart failure patients, and sweating. We know very well that the postganglionic sympathetic neurons to the sweat glands release acetylcholine that will act on muscarinic receptors, and this sympathetic stimulation to the sweat glands will lead to cold, clammy skin in heart failure patients. The renal compensatory mechanisms will lead to reduced urinary output during heart failure, and this happens through several mechanisms. So several mechanisms that cause renal fluid retention as a compensation during heart failure include activation of the sympathetic system, and this will lead to vasoconstriction of the afferent arterioles, and in turn will decrease the GFR or the glomerular filtration rate, and reduction in the GFR will increase the fluid retention, will decrease filtration through the glomeruli. And also sympathetic stimulation will stimulate the renal tubular reabsorption of water and salts, also stimulate the renin release and angiotensin II formation, and also will stimulate the antidiuretic hormone release from the posterior pituitary gland. Decrease in cardiac output will decrease the mean arterial pressure and will reduce the renal blood flow. Reduction in renal blood flow will reduce the GFR, and again this will lead to increased renal fluid retention. For example, a 50% reduction in cardiac output can lead to anuria, a formation of very small volume of urine. Another way how heart failure or renal compensation will work in heart failure, reduction in the cardiac output. A reduction in the cardiac output will decrease the mean arterial pressure, and this will lead to reduced renal blood flow, and this will activate the renin-angiotensin system, renin secretion and angiotensin II formation, and the final result will be water and salt reabsorption and increase in blood volume. Also, an increase in angiotensin II will increase aldosterone secretion from the adrenal cortex, and this will lead to increased sodium reabsorption, and this will be followed by osmosis of water, and the end result is an increase in blood volume in a trial to restore the low cardiac output that happens in heart failure. Moreover, aldosterone secretion will increase sodium and anions reabsorption. This will increase plasma osmolarity, which will stimulate the antidiuretic hormone secretion from the posterior pituitary gland, and this will result in increased water reabsorption in the kidneys. Now the question, or the common question, are these compensatory mechanisms beneficial or harmful? Is sympathetic compensation beneficial or harmful? And whether the renal compensation is also beneficial or harmful. We know from any biological system that any feedback mechanism or any compensatory mechanism is beneficial to within a certain limit. If we exceed that limit, then the compensatory mechanism will become harmful, and this applies to the heart failure, both for sympathetic and renal compensations. For example, the beneficial effect of sympathetic compensation when there is immediate sympathetic reflex within few seconds after acute drop in cardiac output. This is beneficial in helping to recover the cardiac output near to normal by increasing the venous return, according to the Starling law, and the stroke volume. However, sympathetic overstimulation will place further strain on the myocardium, and this will increase the coronary perfusion requirements and will worsen heart failure that is caused, for example, by ischemic heart disease. Also, sympathetic overstimulation may cause potentially fatal abnormal heart rhythm or arrhythmia, because we know that also sympathetic stimulation of the heart will increase the heart rate. So overstimulation can lead to fatal arrhythmias. Again, heart muscle fiber will increase in size in an attempt to improve contractility, and this is when there is chronic sympathetic overstimulation. This will lead to increased stiffness of the heart chamber, decrease the ability to relax during diastole, and this will lead to diastolic heart failure and a decrease in diastolic volume and a consequent decrease in the stroke volume. Moreover, chronically high levels of circulating catecholamines that are released by the sympathetic nervous system and the adrenal medulla during conditions where there is sympathetic overstimulation will lead to structural remodeling of the heart, and this will lead to enlargement of the ventricles, and in turn this will lead to inefficient contraction of the heart and the reduction in the stroke volume. All these points from 1 to 4 will increase the risk of cardiac arrest. So as I said, immediate sympathetic stimulation will try to restore the cardiac output near to normal and save the life of heart failure patient, but sympathetic overstimulation over time can put the patient at risk of cardiac arrest and death. The same question also applies for the renal compensation, is whether renal retention of fluids is beneficial or harmful in heart failure patient. Moderate fluid retention in cardiac failure or heart failure patient can be beneficial, while excess fluid retention in severe cardiac failure can be detrimental or harmful, and we'll see that when we'll study the cardiac output and venous return curves in compensated and decompensated heart failure later on during this lecture. Moderate increase in body fluid and blood volume is an important factor in helping to compensate for the diminished pumping ability of the heart by increasing the venous return. According to the Starling law, will increase the end-diastolic volume, and this will lead to stronger force of contraction and higher stroke volume. The increased blood volume that is caused by renal fluid retention will increase the mean systemic filling pressure, and this will in turn will increase the venous pressure gradient and will improve the venous return towards the heart and results in higher stroke volume according to the Starling law, and eventually higher cardiac output. When there is excess fluid retention, because the heart is already pumping at its maximum capacity, further renal fluid retention is no longer beneficial and will cause serious physiological consequences. For example, this will increase the workload on the damaged heart, so the heart will further fail. There will be overstretching of the heart with the extra venous return, and this will further weaken the heart. There will be filtration of fluid into the lungs, causing pulmonary edema and consequent deoxygenation of blood. And finally, there will be excessive edema will develop in most parts of the body. Now let's remember the four Starling forces that determine the net filtration pressure, and let's see how a change in one of these forces will result in the symptoms and signs of heart failure. As you remember, we have four primary forces. We call them the Starling forces that determine whether the fluid will move out of the blood into the interstitial fluid in the process of filtration, or in the opposite direction, or what we call reabsorption. The four forces are the capillary pressure, which is the hydrostatic pressure caused by the presence of blood in the capillaries. Then we have the interstitial fluid fluid pressure. It is the hydrostatic pressure of fluid present outside the cell, between the cells and outside the capillaries. Then we have the capillary plasma colloid osmotic pressure. It is mainly caused by the plasma proteins and mainly albumin, as you know. And finally, the interstitial fluid colloid osmotic pressure, which is due to the presence of small amount or small concentration or low concentration of proteins in the interstitium. So which forces will promote filtration and which forces promote reabsorption? Let's start with the capillary pressure or capillary hydrostatic pressure. Obviously, it will promote the filtration of fluid from the capillary into the interstitium. Then the interstitial fluid hydrostatic pressure theoretically will promote reabsorption, but this pressure is negative due to the presence of lymphatics in between the capillaries and also the cells. So it is negative, therefore it will promote filtration of fluid from the blood into the interstitium. Another force that will promote filtration is the interstitial fluid colloid osmotic pressure. This will drag water by osmosis outside from the capillary lumen into the interstitium. And the only force that will promote reabsorption is the plasma colloid osmotic pressure. As you remember, the net filtration pressure is can be obtained by employing this equation. So we just subtract the pressure that will promote reabsorption from the total of the forces that promote filtration. Let's apply this concept apply those Starling forces to the systemic capillary. As you might remember, in the systemic capillaries, we have forces that tend to move fluid outward or that promote filtration, and this is the mean capillary pressure, which is about 17.3 millimeter mercury. We have a negative interstitial fluid pressure, which is 3, and we have the interstitial fluid colloid osmotic pressure, which is 8. So the total outward or filtration force is about 28.3 millimeter mercury. The forces that tend to move fluid inward or reabsorption, we have the only force, which is the plasma colloid osmotic pressure, which is 28. If we subtract 28 from 28.3, we have a net filtration pressure of 0.3 millimeter mercury. So you can see here that the mean capillary pressure, as I said, is 17.3 millimeter mercury. If we have patient with heart failure. In a patient with heart failure, if the heart or the cardiac output drops dramatically, what will happen to the pressures in the circulation? The mean aortic pressure will decrease to 13. The capillary hydrostatic pressure will decrease or will drop from 17.3 to 13, and the right atrial pressure will increase from 0 to 13 millimeter mercury. So in acute heart failure, the mean capillary pressure will be 13. So in acute heart failure, capillary pressure falls to 13. So there will be no peripheral edema because the net outward force will be negative. So this will not lead to excessive filtration of fluid into the interstitium and will not lead to edema. What happens in chronic right heart failure, due to the renal compensatory mechanism, there will be renal fluid retention, marked increase in the capillary pressure. So this capillary pressure will increase dramatically. Let's say it will increase to 20 or 22 or 25, and this will lead to an increase in the net filtration pressure. So the net filtration pressure will become, for example, 3, 4, or 5 millimeter mercury, and this will lead to excessive filtration of fluid into the interstitium and will result in peripheral edema. Therefore, in acute right heart failure, we will not see peripheral edema. Peripheral edema happens only after the renal compensatory mechanism will come into effect and will start to increase the blood volume, and this will increase the capillary pressure or the capillary hydrostatic pressure, with resultant increase in net filtration pressure and massive filtration of large amount of fluid from the capillaries into the interstitium, and this will result in edema. Now let's apply the same Starling forces concept to the pulmonary circulation. In the pulmonary circulation, the same four Starling forces. We have the hydrostatic pressure, we have the osmotic pressure of the plasma colloid osmotic pressure. So we have the hydrostatic pressure in the capillaries and in the interstitium. Also we have the osmotic pressure of proteins present in the blood and proteins present in the interstitium. Again, we have the lymphatics, and we have the alveoli with the surface tension. Okay, so what are the forces and what are the values of those four Starling forces? We have the capillary pressure, which is 7, not 17.3. It is much lower because we know that the pulmonary circulation is a low pressure circulation. We have the interstitial fluid colloid osmotic pressure 14, which is higher than the systemic circulation because the pulmonary capillaries are leaky to proteins. And the negative interstitial fluid is also lower. So there it was -3. Here it is -8 because we have the lymphatics plus the surface tension. So this will place more negative pressure on the interstitium. So the total filtration force or the total outward force is 29 millimeter mercury. Now the only force that tend to move fluid or absorption of fluid into the capillaries is the plasma colloid osmotic pressure, which is 28. So the total inward force is 28, and the net filtration pressure is +1. Now what happens if there is a heart failure? Here I said that the pulmonary capillary pressure is 7. What happens if there is acute left heart failure without concomitant right heart failure? Blood continues to be pumped into the lungs by the normally functioning right ventricle, but the left ventricle is not able to eject that blood. So there will be pulmonary vascular congestion, and this will lead to increased pulmonary capillary pressure, much higher than 7, the normal value, especially if it reaches values more than the plasma colloid osmotic pressure. You will study that in the respiratory system, that if the pulmonary capillary pressure reaches a value of 28 millimeter mercury, this will lead to severe pulmonary edema, and this is really very serious condition because it can be so rapid and cause death within 20 to 30 minutes. The pulmonary edema is much more serious than the systemic or the peripheral edema caused by right heart failure. So it should be taken seriously and treated promptly. Now, what is the role of low pressure receptors that are present in the atria, veins, and pulmonary arteries? What is the role of those receptors in heart failure? The low pressure receptors are just baroreceptors like the high pressure receptors present in the aortic arch and the carotid sinus, but the threshold for their stimulation is much lower pressure. Both atria and pulmonary arteries have in their walls stretch receptors or pressoreceptors called low pressure receptors. The low pressure receptors are similar to the baroreceptors, the baroreceptor stretch receptors of the large systemic arteries. These low pressure receptors play an important role, especially in minimizing arterial pressure changes in response to changes in blood volume. So what happens? In heart failure, the increased venous return will increase right atrial pressure. This will activate the low pressure receptors present in the wall of the atria as well as in the pulmonary arteries, because also the stroke volume into the pulmonary trunk will be higher. Stimulation of those low pressure receptors will inhibit the sympathetic activity, including the sympathetic outflow to the kidneys. So there will be decreased tubular water and salt reabsorption. This will operate for a few hours to the first days after the heart failure. The question: can this response offset or cancel the compensatory effect of sympathetic stimulation during heart failure? Is it beneficial or is it harmful? The answer is no, because the sympathetic compensatory mechanism will become activated within a few seconds and will reach a maximum in 30 seconds. This mechanism here is a protective mechanism. It is a beneficial mechanism. It will try to limit the harmful effect of renal or excessive renal compensatory mechanism. It will try to stop the effect of fluid retention on the heart failure patients. Okay, now let's talk about heart failure in terms of cardiac output and venous return curves. You know this curve from the lecture of control of cardiac output and venous return. This is the venous return curve. The venous return normally is when the right atrial pressure is 0, the venous return is 5 liters per minute. So if we decrease the right atrial pressure, this will have like a suction effect, or will increase the gradient for venous return, and will slightly increase the venous return, but it will reach plateau because very low or negative right or very low right atrial pressure on the negative side of the scale will cause a suction effect and will close the major veins. If we increase the right atrial pressure, and this is what happens in heart failure patients, what will happen to the venous return? The venous return will decrease because the pressure gradient for blood to flow from the veins into the right atrium will decrease. So if the right atrial pressure will become 7, which is the value of the mean systemic filling pressure, then the venous return will become 0. So when the heart is stopped, I think many of you will ask about the mean systemic filling pressure because it is appearing in this lecture for the second time. Just to remember, when the heart is stopped, flow of blood everywhere in the circulation will cease for a few seconds later, and then without a blood flow, the pressure everywhere in the circulation will become equal. But this will not reach 0. If we put water in a balloon, the pressure inside the balloon will not be 0. Okay? This equilibrated pressure level is called the mean circulatory filling pressure. The mean circulatory filling pressure is also equal to the mean systemic filling pressure because the effect in the pulmonary circulation is very minimal. Okay, now let's talk about the cardiac output curve. In the cardiac output curve, when we have right atrial pressure, an increase in the right atrial pressure means we have a better venous return, because the higher the venous return, this will mean that we have more blood in the right atrium, and this will increase the right atrial pressure. So with higher venous return, the cardiac output will increase according to the Frank-Starling law and with this within a limit until it will reach a plateau. If we put both curves together, we'll have an intersection point between the venous return curve and the cardiac output curve, and this is called the equilibrium point. At the equilibrium point, the venous return is 5 liters per minute, the cardiac output is 5 liters per minute, and the pressure in the right atrium is 0 millimeter mercury. And this is the condition in normally functioning heart. Now, what happens in the heart failure? For example, during myocardial infarction, the heart will fail, so there will be a problem in the cardiac output. There is a sudden decrease in the cardiac output. So the cardiac output here, for example, will become 2 liters per minute, and the point of intersection is here. So the right atrial pressure will increase to 4 millimeter mercury, and as sympathetic compensatory mechanism will come into effect, we reach equilibrium point C, and then a few days later with renal compensation we will receive a new equilibrium point, which is equilibrium point D. So A is a normal equilibrium point where cardiac output is 5 liters per minute, pressure right atrium 0 millimeter mercury. B, equilibrium point immediately after the cardiac output, before the start of the sympathetic compensation. C is equilibrium point after sympathetic stimulation, becomes maximal within 30 seconds, as I previously mentioned, and then D, equilibrium point after partial heart recovery helped by the renal retention of fluid, and this happens hours to days after the start of the immediate effect. Here you can see that this is the normal cardiac output curve. A failing heart, the cardiac output will drop. Even with increased venous return, the cardiac output cannot increase back to normal. And with the immediate effect also, when the heart is failing, the mean systemic filling pressure will not be affected, because this is happening just the first few seconds after the failure of the heart. So if we take the two curves together, cardiac output curve with the venous return curve, we'll have the new equilibrium point, or the point of intersection, which is B, where we have cardiac output of 2 liters per minute, and the pressure in the right atrium, as I previously mentioned, 4 millimeter mercury. Now, the compensation that happens, or sympathetic compensation for acute heart failure by sympathetic nervous system stimulation. It is maximal within 30 seconds after heart damage, and with strong sympathetic stimulation, the mean circulatory filling pressure can increase dramatically due to the venoconstriction, because we said the sympathetic effect will affect mainly the veins. So even with less venous return, due to the sympathetic compensation or venoconstriction, we can go back to the same volume of venous return, as we can see with this dashed line. This is strong sympathetic stimulation. The strong sympathetic stimulation will increase the mean systemic filling pressure from 7 to 14. So now we have a new mean systemic filling pressure, which is a value of 14 millimeter mercury. So if we take the new intersection between the cardiac output and the venous return, we will have the new equilibrium point, which is point C, where we have the cardiac output around 4.2 liters per minute, pressure in the right atrium about 5 millimeter, here you can see millimeter mercury, and the systemic filling pressure is between 12 and 14 millimeter mercury. Then after a few days, there is partial recovery of the heart. So a week or so after the heart damage, helped by the renal retention of the fluid, we will reach another equilibrium point, which is equilibrium point D, where the cardiac output now is 5 liters per minute, and the pressure in the right atrium is 6 millimeter mercury. The main target of the compensatory mechanism, both sympathetic and parasympathetic, is to bring the cardiac output back to 5 liters per minute, because this will stop the renal compensatory mechanism from being harmful, because retention of large volume of fluid will overstretch the failing heart, and this will lead to decompensated heart failure and death. So compensated heart failure Cardiac output returns to almost normal after several days of partial heart recovery and fluid retention. So no further fluid retention will happen. So the renal compensatory mechanism will stop here at equilibrium point D, except for the high pressure in the right atrium, which is 6 millimeter mercury. The person has essentially normal cardiovascular dynamics as long as he remains at rest. As you can see here, he cannot increase his cardiac output, so he cannot perform any exercise or any extra activities. Now we have two terms. I mentioned compensated and decompensated heart failure. Failure of the heart to pump sufficient blood to make the kidneys excrete the necessary amount of fluid every day will lead to decompensated heart failure. So if the compensatory mechanism fail to bring the cardiac output back to 5 liters per minute, then we will enter into decompensated heart failure. The kidney will continue to retain fluid, and the ventricle will be stretched and stretched and stretched, and according to the Starling law, the cardiac output will start to decline due to the overstretch of the ventricular wall and the loss of cross bridges between the thin and thick filaments in the myocardium or in the sarcomere. So this is how the decompensated heart failure will develop after several days, because cardiac output failed to reach the target critical cardiac output level for the normal fluid balance, or to stop the renal retention from being harmful. Again, here in the curve we can see this is decompensated heart failure, and this is compensated heart failure helped with a digitalis drug. What are the conditions that can worsen heart failure? Any condition that requires extra cardiac work, increase in the heart workload, or reduce heart oxygen supply will worsen heart failure. And these conditions include anemia, pregnancy, obesity, diabetes, infections, arrhythmias, endocrine disorders like thyrotoxicosis, etc. What are the principal investigations that can be employed to help or aid in the diagnosis of heart failure? We have different imaging techniques like echocardiography that can help us to determine the stroke volume, end diastolic volume, ejection fraction, the size of the chambers, the state of the condition of the different valves, etc. Chest X-ray that will show us any cardiomegaly, pulmonary edema, and any other abnormalities. Then we have the electrocardiography or the ECG to identify any underlying arrhythmias that are causing heart failure, ischemic heart disease, right and left ventricular hypertrophy, etc. And also we can do coronary angiography to study the lumen, or how patent are the coronary blood vessels. And finally, we can do some blood tests like cardiac enzymes, electrolytes, kidney function test, liver function test, thyroid function test, and also complete blood count, as well as any other test that might help in excluding or help in coming to final diagnosis from a list of differential diagnoses. With this slide, we finish today's lecture. Thank you very much for your patience, and please here the list of references. I used Guyton, Principle of Human Physiology, Stanfield, Human Physiology, Sherwood, and Medical Physiology by Rhodes. Thank you very much and have a nice day.